Okay, so I'll get started. So for those who haven't met me, my name is Ramon. I'm one of the PGY4s in geriatric medicine here at U of T. Today I'll be giving a talk on a recent study that was recently published on comparing the risk and harm of harm associated with trazodone versus atypical antipsychotics in older adults with dementia. It's a retrospective cohort study that was recently published, so I'll be doing the long-term presentation today. So let's start off by saying I have no conflict of interest to disclose. I will talk today about some background information about dementia and the treatment of behavioral and psychological symptoms of dementia, the study in more detail, critical appraisal, and finally discussing some of the important aspects of the study. So a little bit of a background information based on the study. So dementia prevalence in Canada is approximately 7%. That was sorry, I'm trying to get my notes up on a separate screen here. That's based on a study that was recently published in 2017 data. And that was based on the Public Health Agency of Canada. That was published in 2017. The estimate approaches about 25% in those over the age of 85. And again, that was in the same Public Health Agency of Canada publication in 2017. That number goes up to about prevalence of over 60% in long-term care, and almost 50% of those will have a form of BPSD, which we'll discuss a little bit further in the next slide. In terms of the treatment of BPSD, we have very limited evidence in terms of pharmacological measures involving antipsychotics, mostly atypical antipsychotics, as well as trazodone, which have been frequently used. It's about, in these population, about 1/3 or just over 1/3 of long-term care residents are prescribed antipsychotics, and just about 1 in 5 trazodone respectively. So a big chunk of this population will be on these agents. So it was very important to assess what the side effects of these agents are and whether or not trazodone is in fact safer than the antipsychotic use. So in terms of BPSD or behavioral psychological symptoms of dementia, that involves many different symptoms. Usually these agents are prescribed for aggression or agitation, but can be in the form of delusions, hallucinations, depression, anxiety, euphoria, apathy, irritability, disinhibition, wandering off, and sleep disturbances, as well as refusal of care. And a lot of times these agents can be prescribed inappropriately for some of these symptoms, but typically it's mostly to control agitation. In terms of, sorry, one more quick point on that is that usually it's important to identify the precipitating factor of someone who's presenting with these symptoms, especially agitation, to rule out any reversible cause, superimposed delirium, or unmet need. And so it's important that these agents would be used sort of if these symptoms are not controlled with non-pharmacological measures, just because of their side effect profile, which we'll go a little bit more in detail in the next few slides. So in terms of antipsychotics use in the setting of dementia and the evidence behind it, so it's not an approved indication by the FDA for the treatment of behavioral disorders in patients with dementia. And there's very limited efficacy, but there are studies do show that risperidone and olanzapine have some efficacy in this population. There's a systematic review that was done in BMJ earlier on with randomized controlled trials showing some evidence with risperidone and olanzapine up to 12 weeks. So it's very important to reassess the appropriateness of this medication, again, mostly because of side effects and the harm associated with them after they're started and that they're not kept on long-term. They have been shown to decrease some agitation scores in terms of their improvement. Also important to note that the doses that they use in these trials, again, mostly around the 1 milligram dose of risperidone. And once you go beyond that, you start seeing a lot more side effects, mostly with the 2 milligram a day range. In terms of, again, the indication for them is mostly to manage agitation and aggression, but a lot of times they are used for other symptoms, which can be inappropriate at times. In terms of assessing whether or not it's appropriate, it's always very important to continue reassessment, and usually there is a recommendation by the American Psychiatric Association that recommends that an attempt to taper or withdraw the antipsychotic therapy be made within about 4 months in terms of since the initiation of the drug, and see if the patients do relapse back into these symptoms. So it's important to always reassess that. That was a BMJ study that was done in 2014, and our Cochrane database systematic review in 2013. In terms of the risks associated with atypical antipsychotics, so we know that they're associated with falls, fractures, increased mortality, aspiration pneumonia, stroke, myocardial infarctions, and extrapyramidal side effects. That depends on the specific agent, more so with typical antipsychotics with respect to the extrapyramidal side effects. Also, some specific agents will also include metabolic syndrome-like symptoms, which are important to be mindful of. In terms of the evidence behind trazodone, again, no supportive evidence in terms of efficacy in this population. There was no benefit compared to placebo for neuropsychiatric symptoms. That was based on a study in neurology in 2000, as well as there have been a comparison of trazodone with haloperidol in a study that was published back in 1997 that showed, again, no significant benefit compared to haloperidol, but equal efficacy. It's sometimes used for a side effect profile, and that's why I thought that this article was interesting, because a lot of times we use trazodone for helping with sleep impairment, and so it is more commonly used in the geriatric population and preferred in that population, and so I just wanted to explore the evidence behind it with respect to PTSD specifically. So some of the risks associated with trazodone include Parkinsonism, drowsiness, dizziness, hypotension, falls, and which can lead to fractures. That was a study that was recently published in 2017 that looked at antidepressants in general, among which trazodone was one of them. And although they looked at a lot of other factors, they did show clinical significant fall increase and injuries with related to falls among those hip fractures. And again, just showing that a study earlier on showed that there was no significant harm compared to haloperidol. But in this study, we'll see how it is compared to atypical antipsychotics. So without further ado, I'd like to jump into the study and a little bit more in detail. So it was a study recently published by Dr. Jennifer Watt here at UFT, as well as some of you might know Dr. Ho and obviously Dr. Sharon Strauss, that looked at comparative risk of harm associated with trazodone or atypical antipsychotic use in older adults with dementia. And it was a retrospective cohort study that was published in the Canadian Medical Association Journal just a few months ago. The objective of the study was to describe the comparative risk of falls and fracture among older adults with dementia dispensed trazodone or atypical antipsychotics, and it was that was the primary outcome. But they also looked at mortality and separate indices and for their secondary outcomes as well. That I'll go a little bit more in detail in. In terms of the study design, so it was a retrospective cohort study, fairly large among various centers that looked at long-term care residents over the age of 65 with dementia, and they compared those who were dispensed trazodone versus those that were dispensed one of the atypical antipsychotics, and that included quetiapine, olanzapine, and risperidone. The doses that they limited to the inclusion criteria is basically any dose that's up to an equivalence of 300 milligrams of trazodone, and they used that to be an equivalent of a maximum quetiapine dose of 300 milligrams per day, a risperidone maximum dose of 3 milligram, which is a fairly high dose, but we'll see that most patients were actually on the lower end of dosing, and olanzapine up to 10 milligrams per day. That was conducted between December 2009 to December 31st. 2015, allowing for a 3 months follow-up, which was the duration of follow-up they had. So last follow-up was up to March 31st, 2016. They screened over 200,000 patients that will go a little bit more in detail in the next few slides based on the flowchart, but 9,463 participants met the inclusion criteria. Just over 2/3 were trazodone prescribed patients versus just under 3,000 were the atypical antipsychotic group. Some of the exclusion criteria in the study included not having a completed international resident assessment instrument, which they used to assess the overall health and comorbidities of patients to gather history on. And they had to have that done within 30 days of the cohort entry. Also, those that received antipsychotics or trazodone within a year before the cohort entry, they were excluded. They have no documented history of dementia, obviously. Those that were dispensed more than the one drug within the trial, so either the trazodone and then another antipsychotic, one of the antipsychotics within the cohort entry. Finally, there was a point about if patients had chronic psychiatric illnesses for some reason and had other indications for being on antipsychotics within the past 2 years of the cohort entry, they were also excluded. However, in the flowchart, it mentions that it was a 5-year period of any of psychiatric diagnosis. So it's not fairly clear, but at least 2 years based on what's described in the actual article. Those who received palliative care in the past 6 months, and again, that's because of the certain doses that they use and the indications for some of these agents. Those younger than the age of 66 or over the age of 105, and those dispense more than the maximum dose that they allocated at the beginning of the trial. In terms of, this just illustrates what we just talked about in terms of starting with just over 200,000 initially, and moving down, just 10% of those had an assessment done within 30 days, so they were able to move further into the inclusion criteria. Those that had antipsychotics in the past year or so, just a few, just about 10% of them kind of moved on to the next phase, and basically ended up with the end results of the 10,000 or just under 10,000 patients that they were included in the study. This table here summarizes some of the demographics of the patients in the study. I'd like to point out on the right side here that the baseline characteristics that were identified more in detail in Appendix 3 table were considered similar in both the standard, using the standardized difference of about 0.1, which basically was evident for all the characteristics, so they were considered to be equivalent. Most patients had significant comorbidities and heavy number of prescription drugs, as you can see here by the highlighted box. Just under 20 medications for the trazodone group and just over 17 for the atypical antipsychotic group. Again, it was considered a non-significant difference between both arms, but overall it just tells us a little bit more about the population that was studied. Also like to mention that the average age of the patients in the study was about 85, just over 85 years of age, and 2/3 were females. Also, in terms of the antipsychotic distribution among the just under 3,000 patients, a bulk of them had quetiapine, so over 50%, and over 1/3 had risperidone, and just under 10% had olanzapine. In terms of the dosing that they were prescribed, again, 95% or just over 95% had an equivalent dose of olanzapine 2.5 milligrams. So even though the set maximum dose was a lot higher for inclusion purposes, most of the patients were more on the lower dosing regimen. And that just goes on further with table 1, again showing in the box specifically highlighting those who were on other psychoactive regimen, a fairly large group of both arms of the study. And so the bulk of patients being on these agents, again, although it might not make a difference between the results of both arms, they do indicate that there could be, it doesn't take into perspective interactions with the antipsychotics or trazodone and other potentiating some of the side effects that we'll see sort of documented in this study. Also, something that was not mentioned in this table, but was mentioned in the supplemental table 2 and 4, if you had a chance to look at that, 50% scored 0 out of 12 on the aggression scale. And so it was not very clear what the indication is for some of these prescribed antipsychotics and trazodone. So it was sort of something that's interesting that's mentioned in that table as well. In terms of collecting data, so various sources, they use the ODB or Ontario Drug Benefit Program. They use the data from ISIS, Ontario Mental Health Reporting System, National Ambulatory Care Reporting System, Ontario Health Insurance Plan Database or OHIP, Registered Persons Database, Discharge Abstract Database, and Continuing Care Reporting System. So various sources, and given that it's a public healthcare system here in Canada and Ontario, we have access to some of these especially the ODB program and OHIP information to collect this data, which was pertinent. In terms of some of the outcomes that were discussed in the trial, so primary outcome, as mentioned earlier, looked at falls resulting in an ED or emergency department visit or a major osteoporotic fracture, and that included hip fracture, pelvis fracture, humerus fracture, or forearm fractures. Looking at secondary outcomes, they looked at all-cause mortality, falls alone as a separate category, major osteoporotic fractures alone, hip fractures alone, and they intended to look at subgroup analysis in terms of outcome based on age, sex, and dementia severity, as well as the different dosing groups, whether it's low, mediate, or intermediate, or high, but they ended up not completing due to the sample size. And again, as mentioned, that most of the population were actually on the lower end of dosing when it came to dispensing. They used a tracer outcome of cataract surgery, again, to just assess sensitivity of findings of the unmeasured confounders, which, as expected, there was no association between trazodone and antipsychotic treatment in those with cataract surgery, which just validates some of the results. In terms of primary analysis, so that was an intention to treat analysis versus their secondary analysis. They censored those that were dispensed a drug from the other class or arm during the 90-day follow-up, but not on the first day, which would have been excluded as part of the trial. In terms of some of the results, again, this just summarizes in a table form some of the outcomes. So as you can see here, I highlighted in a red box here the ones that were statistically significant. So there was similar rate of falls, major osteoporotic fractures, hip fractures between trazodone users and atypical antipsychotic users. The one thing that showed some statistical significance was the all-cause mortality. Both in the primary analysis, which was the intentional to treat group here, up here, as well as the secondary analysis after censoring for switching the exposure groups. In terms of whether or not this is surprising, so it is expected, and we do know that there's a black box warning with antipsychotics and increased mortality, which was previously shown in various prior studies. I did want to highlight some of the starred items here. Although they did not meet statistical significance, they did show a trend towards trazodone being better. However, it did cross 1 in all of them, and so it was considered not a statistical significance outcome with respect to the other features. And also want to mention that conclusions were unchanged using propensity scores to derive the inverse probability of treatment weights and using subdistribution hazard analysis for computing risk of death showed no change in terms of these results. So it was fairly consistent. So coming down to sort of discussing the strengths and weaknesses of the study. So it was a large study, reasonable follow-up, given that the recommended assessment, as indicated earlier, for prescribing these agents is usually around the 3 month mark. So having a 90-day follow-up was adequate. It was ethics approved by U of T as well as Sunnybrook Health Sciences Center Ethics Board. Sensitivity analysis, again, using high dimensional propensity score, which showed some results that were consistent across the board, so validating some of the results. So for sensitivity analysis, they included age, sex, cognitive performance, dependency, year of cohort entry, presence of delusions, aggressive behavior scores, depression rating scales, weight, wheelchair, ambulation ratios, number of geriatrician visits per year, history of major osteoporotic fractures or falls leading to hospital presentation. So a lot of the things that could affect the results were included. It wasn't intentional to treat studies, especially for the primary analysis. So that was another strength of the study. In terms of the cause-specific hazard ratio, that the model that they used, it was used to allow for understanding the association between the exposure drug and the rate of outcome in participants who were event-free. So it helps identify the risk of the event, which was also something that's a strength in the study. And again, just want to highlight that between the various analysis, they did show consistent results between the primary and secondary analysis, so that was consistent. In terms of some of the limitations, so again, being non-randomized, and as with most other cohort studies or retrospective cohort studies, the possibility of unmeasured confounders. It's also unclear to me, which I think was the one thing that I would have wanted to clarify further, was the rate of actual exposure to the drug or compliance. Now, having said that, they were long-term care patients, and so you'd expect that if they are prescribed a standing order of a drug, that they would be taking it. But there was no mention about the MAR being reviewed or whether or not dispensing the agents actually translated into the patients taking these drugs. So a lot of most of what's mentioned is that the inclusion criteria included those that were actually dispensed rather than taking the drug. In terms of applicability to the general population was another point that I wanted to bring up. So because most of the patients studied and the average age was over 85, they also had significant comorbidities. It's unclear if this can be extrapolated to patients who are less significant, severely frail, as was in that group, as well as those that are not in long-term care and in other settings. So that was another important point, as well as underestimating the risk of falls. So they included for the primary outcome those clinically relevant falls that led to emergency department visits. Again, that's assumes that patients in each arm experienced the same number of falls that are also non-clinically significant or haven't led to a hospital admission or presentation to the emergency department or fractures. And so it might have missed a lot of falls that have not led to these results, and that was not mentioned in the study in terms of whether one group had more falls that are not clinically significant compared to the other group. And again, although it is recommended that these agents would be reassessed at 90 days mark, which I thought was appropriate for the 90-day follow-up that was in the study, some of these patients do fail the weaning trial and are on it for much longer. And so it's not clear if the results can be applicable for those who are on the agent long-term, and whether or not certain side effects would be worse with one arm versus the other if they're on the drug for more than 90 days. So using the Newcastle Ottawa Quality Assessment Scale for cohort studies, looking at selection of the group versus comparability of the group and outcome measures, and using the score of up to 9 stars for assessing the study. I gave the study an 8 out of 9, so fairly robust and good study overall. They looked at the specific selected group that was kind of matched to the between the trazodone and the antipsychotic group drawn from the same community. They also had secure, accurate records of everything that was, or all the factors that could have been confounders or were included in the trial. And they also demonstrated that outcome of interest was not present at the start of the study by excluding certain groups that might have had some confounders like exposure to a form of the antipsychotic or trazodone in the past year to minimize that being a confounder. In terms of comparability between the groups, again, they looked and assessed a lot of confounders that could have affected the results. They had very consistent results overall, and the study controls for any additional factors was also considered, and so we got 2 stars for that. And finally, in terms of outcome measures, in terms of assessment of outcome, it was based on a recorded data. The follow-up was long enough, again, with respect to how these agents are usually prescribed in practice. I thought 90 days was adequate. And in terms of follow-up, again, complete follow-up, although that's another factor that was not explicitly described in the study. There was no mention about anyone falling out of the study aside from if very few patients actually passed away within the study, and so they had a analysis for the confounding factor or the competing factor of dying. So a total score of 8 out of 9. So in terms of conclusions, trazodone cannot be assumed to be uniformly safer alternative to atypical antipsychotics for BPSD management, as it was associated with a similar risk of clinically significant falls and major osteoporotic fractures in the moderately to severe frail and more older population of long-term care residents with dementia, although it was associated with a better overall 90-day mortality than atypical antipsychotics. So there was this benefit there. But overall, I think we do need more randomized controlled trials to kind of establish that benefit and whether or not it can be extrapolated to a broader population demographics, such as those in the community, or less frail or younger population, younger than the age of 85. These are my references, and I'd like to open it up for questions.